Hi, so I'm Kathleen Muldowney, and I'm here with Kevin to tell you about how we evaluate patients with Ehlers-Danlos. So first of all, as a disclosure, we do have a company, Muldowney Consulting, but we're not going to discuss that today. We have a book and a protocol, but again, we're just going to go over more general evaluation today. So a little bit about us. We own 2 physical therapy clinics in Rhode Island, and we've been treating patients with EDS for over 10 years now. And we currently have, between the 2 offices, we see about 125 EDS patients a week. So we've been fortunate to work with thousands of EDS patients over the years, and which has allowed us to really recognize a lot of common comorbidities like POTS, mast cell, things that we've talked about today already with the other presenters. And we also, just kind of get a good feel for a lot of common things that happen with this population. We treat people with EDS who are from all over the United States, and we've also had people from other countries come to see us. So patients need to have really a team of practitioners to help. Typically, they do have quite a few issues going on, systemic issues such as POTS, mast cell, GI issues, allergies, neurological issues like CCI, AAI, Chiari, tethered cord, bulging disc, spondylolisthesis. Also, patients with EDS can also have common orthopedic injuries such as labral tears, meniscal tears, rotator cuff tears, capsular instability, and of course the joint hypermobility. And any joint that has hypermobility that needs to be assessed if it needs strengthening or bracing or surgery. So some members of the team that a lot of our patients have are a geneticist or rheumatologist, primary care physician, cardiologist, neurosurgeon, neurologist, mast cell doctor, pain doctor, gastroenterologist, and a support group of peers, and then, of course, us, the physical therapists. So you need quite a few people to kind of, help with all the issues that commonly arise. So one way we kind of look at the EDS patient is kind of as a pie and sort of pieces of the pie. And we have to, again, have this team, which we call Team Awesome, to help, address all these issues. And if all these other issues aren't cleared, such as cardio, the neurological issues, allergies, GI things, then it's very difficult for the patient to be successful with physical therapy because, again, all these other systemic problems are causing problems for the patients, and then they're not able to exercise or kind of do the physical therapy. So we want to make sure that all the pieces of the pie are taken care of to help our patients. So how can physical therapy specifically help someone with EDS? So basically, again, there's a lot going on with these patients, but the joint hypermobility that is from the EDS is what we focus on. So often these patients will have poor posture, they'll have issues with their gait, endurance, strengthening, balance, and again, communication with other members of the team is really key. And we do focus a lot on that in our practice. And a lot of times the patients are overwhelmed and they kind of don't know which direction to turn in. So we really try to help kind of focus them and direct them with that. We also believe in educating our patients on how to live with EDS. Again, it's a chronic condition. Something is always going to kind of come up for the patient. So we really try to educate them and try to give them little tricks and tools and things that they can do at home to help themselves. We also work a lot with their family members to show them different techniques, some self-correction techniques like fixing an upslip or taping something that can, help the patient. Again, inevitably something's going to pop out on a Friday afternoon of a holiday weekend when we're closed. So, we like to, again, give our patients, the best chance to be successful and live a pain-free life. So how does Muldowney Physical Therapy look at a patient? So we look at all the patients through biomechanical lenses, and basically biomechanics is a study of the mechanical laws relating to the movement or structure of living organisms. So this allows us to look at a patient and determine where's the pain coming from. So we may have a patient that comes in with neck pain and says, hey, it's just my neck, why don't you do your thing here and fix me up? But, that may not be where their pain is coming from. So again, a lot of times with patients with neck pain, a lot of the pain can be coming from the shoulders. So we kind of have to look at the patient as a whole and really assess, where that pain is coming from to really treat it appropriately. So what we as physical therapists want to do is restore the proper biomechanics to a specific joint. And like I mentioned before, we want to refer to proper healthcare team members to help with the other issues. So let's say the patient has POTS and that's not being addressed. We want to make sure they get that taken care of, and then we kind of, can come in and do our thing. So the way that we're going to restore the biomechanics is through manual therapy and exercise. So different manual therapy that we utilize is muscle energy techniques, craniosacral therapy techniques, Mulligan techniques, myofascial release, and taping. And then again, like I said before, we also teach patients to fix themselves or have family members assist with that to help. And then we're going to use exercise to stabilize the joints. So we spent a lot of time, many years, kind of looking through different exercises, because there's millions of different exercises you could give a person. And we want to look at how it affects the whole body, not just that joint. So you may give a patient an exercise that's a great hip strengthening exercise, but now you may be popping out, their SI joint or their shoulder because of the position you have them in. So we kind of have to look at all those aspects to really pick, what's going to work for the patients. And the other thing that we utilize with our exercises is just a slow progression to decrease the risk of injury. And what we found is that with the EDS population, you can't progress them too quickly. You can't be too aggressive, and sort of the philosophy of no pain, no gain does not work. So we kind of have the opposite of that philosophy in our clinic. So how can physical therapy decrease a patient's joint pain? So basically, why does a joint sublux? So it's pretty simple that when the external forces of the environment are greater than the ligamentous strength or the muscular strength of the joint will sublux. If it's not, then it won't. So an example of that is, let's say someone's doing laundry and they say, what, every time I do laundry, I carry the basket up the stairs and my shoulder pops out and it subluxes. So what we want to do is, we want to prevent the joint from subluxing. And there's kind of three ways to approach that. You're either going to strengthen, you're going to modify the activity, or you're going to tape or brace. So again, with the person with the laundry, if you're going to strengthen, you're going to strengthen the muscles around the joint so they can absorb the greater forces of carrying that laundry basket. So you may focus a little bit more on the rotator cuff strengthening. Say when the person reaches a higher level of exercise, maybe now they say, hey, you know what, I can carry that basket of laundry and my shoulder doesn't pop out anymore. So that's one way to address it. Another way is to modify the activity so that the forces are less on that joint. So maybe you have the person carry half a load of laundry and then their shoulder doesn't sublux. And then the last way would be either to brace or tape. And again, we want to think of those things as we're going to brace for an activity, not for life. So you say, hey, you know what, when you have laundry day, tape up your shoulders. That way you can, do your laundry and get your things done, or a brace or things like that. So our evaluation of a patient with EDS on the subjective end of it. So we want to kind of go through and find out what our goals are for the patient. And again, like we mentioned before, what other members of the healthcare team does a patient have and who do they need to have on their team? So we kind of, go through some quick screening questions to try to find out what their issues are. May they have, POTS, mast cell, GI issues, things like that. And then kind of direct them to the proper other team members if they don't have them already. And then you also want to find out what their current functional activity level is. I mean, we see people from all ends of the spectrum. So some people, are they bedbound? Is it a student? Is the person working? Do they have kids? Kind of what are we looking to kind of get them back to? And then a big thing that we find too is home support. And that can make, quite a big difference on kind of how you're going to progress the patient, what suggestions you're going to make for them. Do they have a spouse or, family members who can really help them out? Do they live alone? So you want to kind of take all those things into account and kind of work around what the person has. And then you want to find out, what are the major problems that the patient is having and what are their goals? What do they, want to get back to? Is it, going to their kid's soccer game, be able to walk across the grass without, popping everything out? Or is it they want to get back to work, or kind of what you're looking towards? And then you want to look at what the average pain level is of every joint and kind of write it down with a number. And that's just kind of a quantitative way to track progress. And then you want to look at assistive devices and braces. And that doesn't just mean crutches or walkers. There's a million different little gadgets and things out there to help EDS patients. Some are finger splints. Maybe it's something to hold their pen so when they're writing, it's more comfortable. Maybe something to hold their phone. And on our website, we do have quite a few suggestions of different assistive devices and braces that patients have we figured out to help our patients. And, if a patient comes in too and they have some kind of cool thing, or say they like to knit and they have certain knitting needles that, are more comfortable for their hands, we'll actually take a picture of it, or we'll kind of write it down. And that way we kind of keep this whole list of, little gadgets and things that the patients like, so that if another person comes in, we can kind of pass that on and help them out too. So different techniques we use for our subjective evaluation. We use questionnaires, try to ask yes and no questions, build trust with the patient. We kind of want to explain kind of, where we're coming from and what we do. And what we find is a lot of the patients, when they come to us, are pretty anxious. They usually really don't like physical therapy, which is really great when they walk in the room and say, I really don't want to be here. But but I understand that, they've had some bad experiences, and they're, may have had, some difficulties, with other healthcare professionals, and they're, just kind of anxious that, nobody's going to understand them. And but what we tell them is, we kind of let them know that we've seen a lot of people we do understand, and, that's important to kind of let them know that. And then explain what we can and cannot help with. So PT cannot fix everything with EDS by any means. But again, we kind of focus on the physical, pain from the postural deficits and subluxations. And then we want to explain to the patient that, we do have a limited time for the evaluation, and we don't want to give too much extra information that first day, because then you'd probably, be there all night. But, fortunately, in our practice, with the local patients, we do get to see them 2 to 3 times a week. So we do have, spend quite a bit of time with them. So we say, next time when you come in, let's talk about the GI issues, or let's talk about this. And then we give them, 5 minutes at the end to just kind of add anything extra that we didn't touch upon. So objectively for the evaluation, we want to look, first we're going to look at posture, and we look at it from an anterior posterior point of view at first. Oftentimes what you'll find is a scoliotic curve. Most of the patients will have pronated feet. Then you want to kind of ask them, do they have orthotics, or kind of make a note to address that with them at a later date. A lot of times you'll find valgus of the knee, which is caused by the pronated feet. The scapular are often protracted and asymmetrical, and the shoulders are usually asymmetrical. And usually we find the first rib is elevated because of the tight scalenes, the upper trap and levator, and then the pelvic heights, which are usually asymmetrical as well. And then we want to look at posture from a side view here, and the person on the left is someone who had, gone through physical therapy, and you can see that her posture is quite nice. The person on the right-hand side is someone who has not finished the exercise, our regimen with them, and that's more of a typical posture of what we see when people first come to us. And what we usually notice is an increased lumbar lordosis, an increased thoracic kyphosis, where the head and shoulders are forward, which is going to lead to increased cervical flexion, increased OA extension, because again, they need to keep their eyes kind of level as they're walking. Oftentimes the shoulders will be forward. You see recurvatum of the knees and flexed hips. And then one thing to kind of keep in mind, that posture will affect the patient quite a bit as far as function and pain. One thing in particular, that in general, the head weighs about 12 pounds, and every inch that the head is forward is going to add 10 pounds of pressure on the cervical spine. So if you have someone who has, say, a 3-inch forward head, they're going to have 42 pounds of pressure on their cervical spine versus someone who's has good alignment and they only have 12 pounds of pressure. So it's, again, that could just, the postural changes could contribute to quite a bit of neck pain. So just to kind of keep that in mind. And then I'm going to pass the torch off to Kevin, who's going to tell you a little bit about low back assessment.
Thank you. So now I'm going to basically go through how we look at someone with EDS. You have someone comes in and they have pain in multiple joints, multiple areas. Where do you start? Most people say they start at the most painful joint. I necessarily don't agree with that, because again, I want to look at a biomechanical assessment. And I'm going to talk about how some things actually affect my assessment. And so where we start is we always start at the low back. We're going to assess the SI joint, the facet joints. We're looking at hypermobility of the spine. We're looking at any disc issues, spondylolisthesis, and any hip issues. So the reason why we start here is I always start at the SI joint, because biomechanically the innominate bone is the top part of the leg, and biomechanically the actual sacrum is the bottom part of the spine. So this is where ground reaction forces from the foot, knee and ankle travel up through the SI joint, and this is where the weight of the head, arm, and trunk come down, make an oblique angle here and go back down when they're sitting. So I always want to make sure if there's any pelvic obliquities here, it is definitely going to affect how I look at the foot and gait. So we have a specific order that we do it in. I don't know what I'm doing here. There you go. All right. So basically what we're going to do is I'm going to measure leg length discrepancy first because I want to make sure there's not a true leg length discrepancy. So we're actually going to either measure, I don't care which one you want to do, ASIS to medial malleolus, or if you want to do greater troch to lateral malleolus, that's up to you. But if there is a true leg length discrepancy, we need to get a heel lift in there. If it is not a true leg length discrepancy, then it's actually a pelvic obliquity, which we need to work with muscle energy to fix. If we do not fix the pelvic obliquity, that will actually bother us when we go to the next section of our evaluation, which is gait. Because again, the longer leg, the foot will be more pronated. The shorter leg, the foot will be a lot more supinated. There'll be an increased valgus at the knee. And that has nothing to do with the gait. It has to do with this pelvic obliquity and what they're trying to actually compensate for. The other thing is, Kathleen talked about how they had an increased lumbar lordosis. So with that increased lumbar lordosis, they're going to have increased mobility of the hip joint with tight psoas muscles, which can actually translate the hip forward. And there could be some actual issues with the hip anteriorly. You can also get some labral tears. You need to make sure that there's no labral fraying over there. So in an MRI, they usually don't tear, they usually fray. So you can't see that on a normal MRI. You need to have an MRI with contrast to see that. There are some techniques that we use in our clinic to help that, and some taping techniques. After that, we actually look at hypermobility of the spine. Again, we're going to actually look at that and do some taping techniques to just assess it. And finally, we're looking at bulging discs. So what we're looking for is when the patient's done with us looking at it, we've done some muscle energy to the SI joint. We've actually worked on the hip and taped it. We've taped any hypermobility of the spine. We're looking at a significant decrease in pain in the low back, 50 to 60% day one. All right, so if we're doing it correctly, we'll get that. If we are not getting it, again, because our patients know that they have tether cord, things like that, any kind of POTS, mast cell, any kind of systemic issues, that can affect this, so that might actually decrease our ability to be successful day one. But again, we need to send them to a practitioner to help work with that. Second, now that we fix the SI joint, we need to look at the foot. Okay, that's a pretty good foot right there. I think that's pronated. So when we look at the lower extremity, we always start at the foot. I'm looking at the navicular and the cuboid as well as the mid-tarsal joint. I actually have some taping techniques I use with the leuco tape and cover tape to actually tape the transverse arch and longitudinal arch. So when they walk, they'll have a better understanding of the foot. So I tell everybody when the foot pronates, it allows the talus to translate forward, which can cause some pain in the anterior portion of the talocrural joint. It'll also allow the knee to go into valgus, which will allow the tibia and the fibula to externally rotate. So you can actually have that nerve entrapment of the peroneal nerve. We use some Mulligan techniques for that. But the first thing I do is we've already fixed the SI joint, and now I've actually taped the foot. I may do some joint mobilizations to the ankle just to make sure that that talus is where it needs to be. And then I'm going to assess their gait. And I think that's the most important thing. I have a majority of patients, after I tape their foot and fix their ankle and SI, they have 0 knee pain, where they came in with 7 or 8 out of 10 knee pain. So we always want to assess that first, just so we know where the pain's coming from. And that's the most important thing with EDS, is you have to figure out where this pain is coming from. And when we assess things, our whole assessment is not so much of where I care where the most pain is. I need to figure out biomechanically what is causing that pain so I can address that joint itself. And finally, I'm a big custom orthotic person. I like soft custom orthotics because they can be easily adjusted. Because again, we got the navicular cuboid, the mid-tarsal joint. I want them to actually fix the talocrural joint as well. So there's a lot of issues they have to address. And also shoes. I don't think I have a picture of it, But I want a good supportive shoe for a pronated foot, because what I tell everybody, if you have a great orthotic on a lousy shoe that bends too much, it's just like putting a great supportive dock in the middle of the ocean. It's not really going to do much of anything. So we need to make sure we have a good shoe as well.
So Kevin, so you know, when you're using your pointer, you use the mouse as arrow. The people online use your
Mouse is arrow.
is the mouse there?
I don't know what the.
Yeah, there's so
Oh, there you go. Oh, beautiful. All right, I apologize to the people online for that. All right, so we can kind of keep going here. So again, so the order we do it in, like I said, we're going to tape the feet and support it. We're going to assess the shoes for stability. We're going to assess the talus. We're going to assess gait at that point. And then if there's any knee problems, we're going to tape the knee. I use a mulligan taping technique to tape the fibula and the tibia. I can also use a McConnell taping for the kneecap. What I find is with this increased valgus at the knee, and the tibia externally rotates and the fibula head goes posterior, if I actually fix it using a mulligan technique and tape it with this tape, most of my patients don't have issues with their patella. So most of the patella tracking is due to the foot being pronated in this increased valgus stress. So again, we have to look at that first. All right, so we've gone belly button down, we're looking belly button up now. So this is the most complex one. Again, I usually do a 2-hour lecture just on neck pain, but we're going to go through this pretty quickly. So common places where the neck has issues. The shoulder is my #1 issue right now. When I tell people tomorrow when I lecture about the neck pain, it's basically the shoulder runs the show. So the shoulder in the EDS patient sublux anterior, but also sublux is inferior. So they have multi-directional instability. And again, when I say this, I'm not saying that every single one has it, but I'm saying a majority does. So there's certain taping techniques that we do to actually tape that. But a lot of us as clinicians, we correct the anterior instability, but we forget that inferior instability. If the shoulder pulls down, it's going to pull on the upper trap. It's going to protract the scapula. It'll have problems right here at the ribs. We're going to have all kinds of issues with the thoracic outlet. The scalene is going to be tight. The first and second rib could be up. So all from this shoulder being pulled down. Again, we can look at posture, which is the most important. So what I do is I usually measure forward head posture from the acromion to the ear, see what it is just for a measurable. And then what we do is we have them just squeeze their shoulder blades back and down. I measure it again. Then I tape the shoulder. I measure it again. And I tape the shoulder with scap retraction and I measure it again. Because what I want to see is this forward head coming from the mid-back, from the shoulder, or is it physically coming from the head itself? So I need to make some determinations on that. So again, it's kind of a little bit of a process to measure it, but I think it gives you a lot of information pretty quickly. So that's what we're going to do with that. Let's see if we can go here. So that's actually my taping technique that I use. I use leukotape and cover tape. This piece of tape is pulling up. This piece of tape is pulling back. We can go over that. Any PTs that want to learn that, that's easy to fix. So we're going to tape the shoulder first. Again, I've had several patients in my lifetime that had severe neck pain after I taped their shoulder. All their neck pain went away. So I want to make sure that we tape that shoulder first just to not have an extra factor when I'm trying to figure out neck problems. We're going to assess posture, like I just said, all the measurements. We're going to evaluate first and second rib. They can actually sublux, causing scalenes to get tight, which can simulate a thoracic outlet syndrome, but it's really the first and second rib. First rib is elevated, second rib is laterally flexed. There are muscle energy techniques to fix that and working on the scalene to make sure there's any radiculopathy down the hand if that decreases it. We're evaluating the thoracic spine, facet joints, and the ribs. Biomechanically, the neck starts at T7, so I evaluate T7 all the way up to C1. And then finally, after I looked at all of that, I finally look at the neck. So all those contributing factors I'm looking at and fixing to see if it contributes to the neck itself. So there's a lot of different things that they can do. I also do a little bit of manual traction to evaluate to see if they have any kind of issues with discs or Chiari malformation. And then finally, I assess the TMJ. Assessment of the elbow, wrist, hand, and fingers. All right, we've already looked at the neck, so we know if there's any radiculopathy coming down. We've already looked at that. We know that. We know if there's any problems with the shoulder causing radiculopathy. We already looked at that previously. As you can see, if we go in the right order, it kind of makes our lives much easier. We're looking at lateral and medial epicondylitis. We're looking at any kind of hypermobility in the wrist and fingers. We're looking at any kind of medial ulnar radial nerve entrapment. Also swelling for systemic events. The wrist and hand is tough because there's really no muscular attachment to the wrist, so we got to protect it and brace it. The major issue with wrist and hands have to do with computer work, cell phone, iPads. Those are all major problems. The one thing that I will tell you, a major cause of wrist and hand pain is POTS. Whoa, how does that happen? The reason is that all of my patients with POTS, when they get up, they get dizzy. Anybody that has POTS? This is what you do. Whoa. That subluxes your wrist, that subluxes your thumb, that subluxes your hand. You don't know you're doing it. Now, if you put that on a couch, I'm going to have instability of my CMC joint. I'm going to look at my pips and dips. I'm going to have problems with my wrists over time. So usually what I have my patients do is they have to fist it. Okay, so stop doing this. I can't actually even put my hand that way because I don't have the flexibility. So all my POTS patients from now on, I'm going to fist it from now on. Okay, don't hurt yourself. That's important. So I don't know, people with cardiology. People with cardiology, I don't know, make sure we tell them that too. That's important. So again, I just told you what we were going to do with the wrist. I use a Futuro sports wrap for the wrist. Dr. Chopra talked about the arthritis gloves that we use, ring splints, so I don't need to go into that. There are all kinds of different assisted devices. If you look at the Writing Bird, there's a thing on, if you Google that on Amazon, they have it. Ask the patients if they're currently using braces or finger splints. But that's the most important thing. It's usually computer work. They need to have something holding the iPad, holding the phone. Amazon has a bunch of stuff like that that they can get. Review of the plan of care with the patient. So what team members they need to see, that's important. So we make a list for them. What areas are being treated first? Again, we're always looking at the SI joint first, regardless of what's going on with the neck and everything else. And then once I explain biomechanically with my patients why we're doing things, they really don't argue with me too much. So I know you might get some kickback, but I never do, if you can explain it. So, and like I said, I treat 125 a week. So what are their responsibilities at home? You know, are they a caregiver? Do they have children? Do they have grandchildren? Do they have to do things? Or are they bedbound all day? You know, you have to kind of figure out what their responsibilities are. How can their family members help them at home? So not only by doing laundry, there are things that I actually teach them. To be honest with you, I teach all family members how to fix the SI joint. So we come in, we videotape it for them, we have a spouse or a family member come in, and that's an entire treatment session, because that's how important I think the SI joint is. And again, if you're only seeing me twice a week and you have a family member that's there every day and you can get it fixed every day, let them do it, all right? And usually most family members are pretty good with that. Also, what is their lifestyle, like I talked to again, and what plan is realistic for them to carry out and be successful? I'll always ask the person, how long do you have to exercise a day, realistically? Everybody says, I have an hour. I go, really, you have an hour every day? Well, I got 20 minutes. And we'll try to modify the exercise protocol for them to fit their lifestyle, because if we don't, they'll be non-compliant. So that's an important thing, to be honest. And unfortunately, my patients are very honest with me, so I don't have to worry about them So treatment, whatever makes you feel bad, don't do it. Whatever makes you feel good, keep it. That seems pretty simple. All right. So they're usually coming to me 2 to 3 times a week. Depending on the amount of support they have at home, I have several patients that live by themselves. So I need to have a little more support from me to help them out, especially at the beginning. We're going to do manual therapy to specific joints. We're looking to decrease pain immediately. So I'm very different from a lot of people that I'm trying to get rid of your pain almost immediately and trying to figure out where that's coming from. We're strengthening all the muscles around the joint, which manual therapy was performed. So if I'm working on the SI joint, they're strengthening all the lumbar spine, okay? We're gonna do modalities as needed. Again, they may have meniscal tears, things like that, that may need some modalities to work on it. Just because they have EDS doesn't mean they can't have an injury, so we need to make sure that we're looking at that stuff. We're teaching family members how to help the patient at home, and we're looking at different bracing, orthotics, and assistive devices. And again, remember, assistive devices doesn't have to be ambulatory assistive devices. It could be fat pens, it could be iPad holders, it could be anything. So I think that's important to know. And finally, as clinicians, we got to remember is we're treating people, not dysfunctions. These people have goals, these people have dreams, they don't care their knee subluxes. We need to actually be realistic with them. So yes, there are the EDS population that are in bed and horrible and that's it. And those are one population, but there are also another population that works and have grandkids and things like that. So this is Nicole. Nicole came into me in a wheelchair, couldn't walk. She had CCI surgery, Chiari malformation surgery, and tether cord. This is her at her graduation. She had never gone to school. She was homeschooled her whole life. She graduated from Providence College, which is in America, and then went off to grad school by herself. And that's us there. And that's just my wife, my son, and me. And again, just treat these people just like they're your family members. That's the most important thing. You have to kind of fit your lifestyle into there. And sometimes we forget that as clinicians. We're always walking about the biomechanical stuff, and we have to look at the person themselves. Questions?